So good evening, everybody, and thank you so much for joining this, our last in the current Women's Health series. And we're going to be talking about testosterone, the forgotten female hormone. So my name is Deborah Evans. I'm clinic owner, director and lead pharmacist at Remedy Health. We're a private pharmacy and clinic, more of that in a moment. And just to say before we start, we are going to be recording this webinar, so you can catch up on it later or share it with anybody else that you think might find it helpful. So let's get cracking. A little bit more about us. We are, from a regulatory point of view, a pharmacy. We're registered with the General Pharmaceutical Council, and we provide a huge range of services, clinic-based, here in Winchester in Hampshire, and we aim to look after our clients and particularly focus on hormonal health, the menopause, perimenopause, sexual and reproductive health, and a range of other services, for example, vaccinations, phlebotomy, etc. We are led by pharmacists, and I personally have almost 40 years experience in healthcare at both local and national level, which does make me almost 60, and certainly have been through my own and continue to go through my own menopause journey. I am an independent prescriber, as is a colleague who also specialises in menopause, Sally Arneson, and I'm delighted to say that we work with a number of other healthcare providers to make sure that where our care stops, we're able to pass on to other, perhaps more specialist services. We're offering something quite unique here at Remedy Health. It enables us to not only have the consultation and prescribe, but also provide medicines on site, which, as you know, with hormone replacement therapy has been a challenge in terms of supply chain. So we work very closely with suppliers to make sure that we don't leave our women without. As I mentioned, we're based in a lovely city in southern England, in Winchester. If you're not based locally, remote consultations are available, but we also love to see people face to face. What are we going to cover this evening? Well, I mentioned it's all about testosterone replacement, and during the previous 4 webinars on the menopause, perimenopause, genital urinary syndrome of the menopause, and hormone replacement therapy more generally, we've avoided, or I've avoided, talking too much about testosterone, so that we could leave it for this final one. We do have links to the previous recordings, so if there are any questions that are broader than testosterone this evening, then I'll see if I've got time to answer them, but otherwise I'll refer you back to those recordings. Now, a few sort of disclaimers, and I think it is really important. We take our clinical governance very seriously here at Remedy Health. We are going to be covering medicines, testosterone replacement, that are only available on prescription. Now, in the UK, it is illegal to promote prescription-only medicines. And so I want to make it clear from the beginning that this is solely for education purposes, and we don't endorse or promote any specific brand of hormone replacement therapy. We will, of course, in our consultations, go through options with our clients, but I'll do everything I can to avoid talking about brands specifically. So I am going to be talking about testosterone, but of course it's no substitute for the individual advice and support that you may have from your healthcare professional or your GP, for example. This presentation is going to explore a range of information around testosterone, but it is really important that if you have specific medical and clinical questions, that you do seek a consultation. But I'll do my best anyway to answer questions at the end, and do post them in the Q&A function on Zoom, so that I can come to them in due course. Do pop the question in as you're thinking of it as we go along, because if you're anything like me, you'll have forgotten about it by the time you get to the end. That way, if I've already answered it, then it's been covered. But if I haven't, I can touch on it. So that's the disclaimers out of the way. What am I going to cover this evening? Oh, I had it up on the screen. So I want to cover the functions of testosterone in women. So what role does it play? What are the symptoms of us being testosterone deficient? What are the benefits and risks of treatment? And what are we monitoring when we do blood tests around testosterone, and why do we do that? So I will make sure that we cover that. And I do want to touch on the regulatory framework associated with testosterone as well, so that you're clear as to what we're prescribing and why we're prescribing it. So we're very focused on good clinical practice within Remedy Health, as you should expect from any healthcare professional. And in particular, we do make sure that we follow guidelines and the evidence where it's available. And of course, evidence continues to be developed all of the time. But I just wanted to sort of really highlight that at the beginning, because as far as the menopause and perimenopause is concerned, there are lots of guidelines out there. For example, NICE, which is currently under review at the moment, the British Menopause Society, for which I'm a member, the Newson Health Guidelines, led by the wonderful Dr. Louise Newson, the British Association of Obstetricians and Gynecologists, the Faculty of Sexual and Reproductive Health, to name just a few. So be reassured that what we're going to be talking about tonight is covered in guidelines and the evidence where at all possible. So if you have attended any of my previous webinars, you'll know this one slide has featured in every single one, and I make no apology for that. It shows just what happens during our reproductive life and beyond to our hormone levels. Now, the main hormone, as we discussed in the last webinar, is estrogen, and it is incredibly important to replace that estrogen, both in terms of symptoms associated with the perimenopause and menopause, but also for long-term health benefits. Now, around the age of 35, our hormones do decline, and estrogen particularly, and goes through a huge variation during the perimenopause. But the declining testosterone is an important element of why we get certain symptoms. And in some women, it explains why even if we optimize their estrogen, they're still symptomatic. And we'll discuss that in terms of the importance of testosterone, particularly neurologically. So let's now talk about testosterone specifically and what its function is in women. So we tend to think of it as a male hormone, which is of course true, but women produce testosterone too. In fact, we produce 3 times as much testosterone than estrogen before the menopause, but of course levels are less than those produced in men. It's produced in approximately equal amounts from our adrenal glands, which are just above our kidneys, and ovaries. And those levels decline sharply around the time of the menopause as our ovarian function decreases. And of course, if you have a surgical menopause or a medical menopause associated with treatment, or indeed premature ovarian insufficiency, where your ovaries fail earlier on in your life, then this testosterone is going to drop off sooner. The levels of testosterone in your body do drop off more sharply around the time of the perimenopause, and then they stay low thereafter. And by the time we reach our mid-40s, if we're an average woman going through the perimenopause and menopause, then our androgenic hormone, so our testosterone, is around 50% of when we were in our 20s. So there is much usually going on in our lives around about our mid-40s. We are probably entering the perimenopause with all the fluctuations that estrogen gives us. But in addition to that, our testosterone is declining and declining rapidly. So what does testosterone do? Well, it's got a range of functions, but it acts as a neurosteroid centrally in the brain, and it affects a variety of functions, including our interest in sex. So testosterone is therefore indicated and prescribed where there's low libido, and more of that later. But it is also important for muscle mass, for bone strength, cardiovascular health, cognitive performance such as concentration, and sort of general cognition. It can also help with energy levels and quality of sleep. So it's not just about whether we're interested in sex or not, but also the pleasure that we get from it. So when our levels of testosterone reduce, we may also feel that not only are we less interested in sex less often, but when we do have sex, it's not as enjoyable. And some women also find it harder to orgasm as their testosterone levels decline, and the intensity of that orgasm also reduces. So with all of that in mind, even if you still desire and love your partner, it can be just something you suddenly find you're no longer interested with. Couple that with the busyness of life, feeling tired, the rest of the perimenopause and menopause, potentially some problems with vaginal and vulval health. It's no surprise that our interest drops off in sex. So what are the symptoms of low testosterone? Well, the fall in testosterone during the perimenopause can lead to this general lack of energy, brain fog, and low sex drive, but also just general lack of motivation, energy, interest in things. We might find when we go to the gym or we work out that we've got lower muscle strength, or we just don't feel we're getting the same results. Definitely, we could see some anxiety, brain fog, mood change, cognitive and memory problems, headaches, and further sort of compounding of any vaginal dryness. And of course, it's very difficult for us to know, is that attributable to low testosterone or is it down to low estrogen? And so really it's about working with your healthcare professional to try and find the right balance for you. And more of that in a moment. So testosterone, like our important hormone estrogen, is involved in many body systems, and those low levels throw up an array of symptoms, and it is difficult to work out what's life, what do we feel is expected as we get older, the stresses and strains, but also what's going on with our hormones, our hormone balance. So when we run a consultation, we try and understand what symptoms a woman is experiencing and if some of her symptoms have been resolved by estrogen replacement. And we feel together that the estrogen has been optimized and that we consider whether an individual will benefit from testosterone. So we do know that testosterone is converted in the body to estrogen by an enzyme called aromatase if the estrogen is too low. So if you think, this is absolutely how it doesn't work scientifically, but if you think about having an estrogen bucket and you need to have enough estrogen in your bucket, if you haven't, then the testosterone that we put in will convert in part to estrogen. And quite a complex biochemical process, and so therefore making sure that we do settle somebody on estrogen first as part of their primary HRT is a really important first step. So often it's in the second or third consultation that we might replace testosterone, or certainly have a discussion about it. So how do we work out what's being caused by too much estrogen, too little estrogen, not enough testosterone? Well, it isn't an exact science, but we do get some clues. So low libido, loss of interest in sex, but also other things such as this kind of brain fog, poor memory, feeling that we're just not on it anymore, loss of confidence, some of those more kind of cognitive, psychological issues that have remained unresolved despite other more physical symptoms having been sorted, like night sweats and flushes, aches and pains, the sort of more estrogenic type effects, then that can give us some clue that testosterone can be helpful. So when we're sort of going through a history and understanding how an individual is responding to their HRT, often the absence, if in fact you had them in the first place, of the hot flushes and night sweats is a good marker for sufficient estrogen replacement. But where there's any query and uncertainty, we also can check the levels of estradiol or estrogen in the blood and make sure that they're at what we would consider sort of an adequate therapeutic level. It is tricky because there isn't always a direct correlation between blood levels and symptom control. Some women need higher levels of estradiol to get good symptom control. But sometimes through trial and error, we can get to a happy place with the hormones. So how do we know when to replace testosterone, and also how do we do it? Well, we listen, understand symptoms, work together. We use that symptom questionnaire that you saw on the previous slide, and then we can consider a trial of testosterone therapy in women who can go ahead with the treatment. So we run a baseline blood test, and if the levels are low, which we haven't yet found a woman who doesn't have low levels of testosterone, we proceed with treatment. If for any reason we have an individual who has a low level of testosterone but simply doesn't have any symptoms, then that's, it really isn't a requirement for treatment. But I haven't yet come across that type of person either. So it's important to say that testosterone isn't appropriate for all women. Clearly, if somebody was still was pregnant or breastfeeding, it would be inappropriate, but also individuals that have active liver disease. And one of the products that we prescribe contains almond oil. So we also ask about allergies to make sure patients don't have an allergy to almonds. So testosterone is usually given as a cream or gel. It's imported from Australia, the cream that we prescribe, and is specifically formulated for women. It's a regulated preparation in Australia, so it has been tested for effectiveness and safety in women. It's rubbed into the skin like a moisturizer and takes about 30 seconds for absorption directly into the bloodstream. And you can do that either on the inner arms, top of thigh, buttock, or above the bikini line. I personally pop it on the inside of my arms directly and rub it. You can see in a moment a picture of that. I do it because I'm engaging with women throughout the day by doing blood tests, and I don't want to contaminate any blood tests by even having rubbed the gel on another part of my body, or the cream, I should say, on another part of my body. But that's an area of low hair follicles and therefore less likely to get additional hair growth in the area. You can also put it on the top of the thigh, buttock, near the bikini line. The reason we suggest those areas is that testosterone, if applied continuously to the same area, just because of the higher concentrations in that local area, can cause some additional hair growth. I am actually quite dark on my arms anyway, in terms of hair, but I find I just have them waxed every sort of 6 months. It really doesn't grow that much, and I probably would have to do that anyway. Now, the gels that are available are made for men, but not tested in women, and they can be used in lower doses for women, and this tends to be how some GPs prescribe it. So just a word about GP prescribing. Not all GPs are comfortable prescribing women, and it does depend on local guidelines within the NHS. And when they do prescribe it, they won't prescribe the product that's imported from Australia. That's only available privately. And GPs, as with all prescribers, will only prescribe within their knowledge and competence. And for some, this is not an area of expertise for them. But you may find somebody in a GP practice who is prepared to prescribe testosterone, but it would be the male product. And there are some challenges with that as well, in terms of the small amount that's applied and the fact that it may not be stable over a few days if you're using some from a little sachet. So your clinician will tell you how much to use. You should wash your hands thoroughly after using it if you've touched the cream, and you should use it the same time every day with the best effect, not least of which it will help you to remember to apply it. And do avoid swimming or showering until about 30 minutes after the application. And you should also avoid using perfume, deodorant or moisturizing creams on the area for about an hour. Now, it can sometimes take a few months for the full effects of testosterone to work in your body. It can be a slow burn, particularly on the libido stakes, but some women notice a difference really quickly. And that's the same whether it's the cream or the gel. And I thought I'd take a picture of how we measure out the cream. This I did in my bathroom this morning. So you measure out 0.5 mils, usually is the standard dose, although that will depend a little bit on how you're absorbing and how you're reacting to testosterone. And you sort of suck it up through the tube. And a key tip here is just to make sure you clean the tube, the syringe out with some hot water immediately after using it. Otherwise, your syringe will quickly get bunged up and you won't be able to measure from it. Now, 0.5 mil looks more than you think. There's my splodge on my arm. And actually, we quite often find when we retest women and monitor their blood levels that they're not using enough, that their levels aren't high enough for a therapeutic benefit. often because they've measured once and then they sort of just apply a P size and it's not sufficient. So I would encourage anyone using this particular mode of testosterone replacement to measure it sort of periodically, perhaps once a week, just to keep yourself on track. You may be somebody who wants to measure it exactly every day. I certainly do mine every sort of 3 or 4 days, just to make sure I'm not under or overcooking it. So who can be prescribed testosterone? So the current UK NHS NICE guidelines only recommend testosterone if you have a severely reduced libido, or what we call hypoactive sexual desire disorder, which I'm going to talk about. But there is good evidence to show that the benefits of testosterone can help more women in their perimenopause and menopause for the reasons that we've already discussed. And menopause specialists such as myself and increasingly GPs are beginning to realise that there are wider spread benefits of testosterone replacement for most women. And we certainly see that in clinical practice. So testosterone, as I've mentioned earlier, can be considered soon after the onset of your perimenopause and menopausal symptoms when you go to seek help for your symptoms. But we at this practice like to get you started and established on your estrogen first, not least of which it can be a little while to settle you on the right dose of estrogen. And if we're also adding in testosterone right from the get-go, it's difficult to know what is having the biggest impact on your symptoms. So let's get you settled on estrogen, progesterone as well if you require it for endometrial protection. And then we can really understand what's having the impact on your symptoms and to optimize that part of your treatment. So it also helps us if you do have any side effects from estrogen or progesterone, that we can get those settled and make sure that everything's in a good place. So when we see our clients, we have an initial consultation with them, which is an hour long for their initiation of HRT. And then 3 months later, we'll have another half hour, more if needed, to discuss how it's going, any outstanding symptoms and any potential issues, side effects, optimizing treatment, maybe changing formulation. There's all sorts of things that we can make happen during that second visit. But also testosterone can be discussed. And actually, if everybody feels that things are pretty stable, but there's still some outstanding symptoms, particularly around libido and cognitive function, then we can move on to looking at testosterone. So I mentioned earlier that we need to make sure that any estrogen deficiency is corrected. And as you'll have heard from our previous webinars, we use estrogen through the skin as it avoids raising a protein in the blood called sex hormone binding globulin. And it's also through the skin lower risk than taking oral hormone replacement therapy. Now, there's another reason why we like estrogen through the skin, and that's because taking it orally as a tablet can increase and raise the sex hormone binding globulin. Now, if we've got lots of sex hormone binding globulin in our blood, it's a protein, and our testosterone attaches to it, rendering it less available for biological activity. So sometimes just a simple switch from oral HRT to transdermal through the skin estrogen can improve symptoms of testosterone deficiency. So it's another thing to factor in to the discussion and thinking. Now, testosterone replacement can be very effective, particularly with women who've gone through an earlier menopause, but we definitely discuss it if a woman's talking specifically about loss of sexual interest, which leads to a whole host of relationship issues. And of course, it's difficult to know what comes first. So if you've lost that intimacy with a partner and that important part of your overall health in terms of your sexual health, then it has an impact on your relationship, or can have an impact on your relationship. But it is difficult to know what comes first. So are relationship issues arising from not having sex, or vice versa? So we do also ask about what's going on, to make sure that we're addressing the right issues. no amount of HRT can address fundamental relationship issues. And so it is important to have that sort of honesty and trust within the client-clinician relationship. We do ask about other symptoms, as we talked about earlier, and that comes through on our menopause symptom questionnaire. So we're going to talk a little bit about monitoring and measuring in a minute, but essentially we do blood tests. Blood tests at the start before we prescribe testosterone, and then we do them again at 3 months and again at 12 months and annually thereafter. So we'll talk a little bit about that as well. One other point to mention is in our third webinar, we talked about genital urinary syndrome of the menopause. And so if you are resuming sex and intercourse after a period of abstinence, because your libido goes up and you've had testosterone, then any issues with vaginal dryness, soreness needs to be addressed as well to make sure that sex is comfortable and pleasurable. And of course, that can be helped with things like lube and moisturizers, but also vaginal estrogens. So what are the benefits of testosterone replacement? Well, you might wonder why I've got a cherry on the cake there, but for many women, it can just be the cherry on the cake. It just completes the picture for them. And of course, we're all different. So for some women, testosterone doesn't make much of a difference. Of course, we need to make sure that they're applying enough. But for others, it's an absolute game changer and they feel much more like themselves. It can add further improvements to those that they've already felt as part of their hormone replacement therapy. So, for example, more energy and stamina, muscle mass and strength, improved concentration, clarity of thought, memory, improving sleep, and of course, libido and sexual arousal levels. So what are the risks? Well, studies that have looked at the effects of testosterone are limited to a 2-year period, but those studies have shown that testosterone is safe when given as a preparation through the skin and in low doses to keep what we call the free androgen index in physiological range for women, which is 2 to 5%. Doesn't cause any increase in blood pressure, has no adverse effect on lipid profile, no impact on breast cancer risk, and causes no endometrial stimulation. So estrogen, of course, can stimulate the endometrium, the uterus lining, but in the studies that are available at the moment, it looks like a safe preparation. But I think the key here and why we monitor blood levels is that we are keeping you within the range that you were in your 20s. So we are not doing anything outside of that. So let's talk about monitoring now, because it is an important part. And as you may be aware, there are very few reasons why we would need to do blood tests specifically on hormone levels during the perimenopause and menopause. They do play a role. And as I mentioned earlier, they can be helpful if we're not quite sure with optimized estrogen. But they do play an important role when prescribing testosterone. So we check levels of testosterone before initiating at the 3 months and then annually thereafter, as I mentioned earlier. And it just so happens we do a full hormone profile, which includes estradiol levels as part of a panel when we do our testosterone. It's just a useful addition, and we just make sure that those are adequate. It also gives us the sex hormone binding globulin so that we can work out this free androgen index. So just rewinding to where I was before, we look at total testosterone, but it's not truly informative as testosterone is significantly protein bound, and that renders it biologically inactive. So we measure that sex hormone binding globulin, that protein, together with the total testosterone to give us this ratio, which is essentially total testosterone times 100 divided by the sex hormone binding globulin. Now, what we're looking to do is replace your testosterone such that your free androgen index is at a minimum of 2% and no higher than 5%. And generally speaking, when we measure somebody's free androgen index before they've started testosterone, I've seen it as low as 0.1%, and the highest that I've seen before replacement has just been under 1%. Now, for estradiol levels, we're looking to get at least 250 picomoles per litre. If they're less than that, then we ideally would increase the estrogen dose first before adding in testosterone. Sometimes we do other tests, such as full blood count, liver function tests, thyroid. We check kidney function, iron, folate, B12, all sorts, if there is anything in that history that we've taken that indicates something else might be going on as far as the dose, the symptoms are concerned. As mentioned earlier, taking estrogen in tablet form can raise the sex hormone binding globulin, therefore reducing the free androgen index, so lessens the amount of testosterone available. It's one of the reasons actually why the combined oral contraceptive pill can cause libido to drop, which of course is ironic, but those of you that were on the pill in your youth may remember that it may have had an effect on you that reduced libido. A high thyroid function and liver disease can also raise the sex hormone binding globulin. So sometimes some of these investigations are secondary to getting that blood test result through if it shows up something. Low thyroid function, being obese and having high levels of insulin also reduces sex hormone binding globulin, but that elevates the free androgen index. So you've got this inverse relationship. If we need to, we can send an individual to our endocrinologist, and we can also check other levels within the blood, for example, something called DHEA, which is produced by the adrenal glands to help us understand if there's a problem with the ovaries or the adrenals. So there's lots of things that we can do. And so the blood test can be super helpful to take us to the next step. But actually, how you feel when you're on hormone replacement therapy is probably the best indicator of knowing whether you're in the right place. And we also need to make sure that you're not experiencing any potential side effects, the most likely of which we would see are excess hair growth on the local area. And you can avoid that by moving around the site of application. So maybe on your inner arms and wrists, then another day doing it on your upper buttock or above your bikini line. Moving it around can help. So we do prefer to do blood tests in the morning between 8 and 10, not least of which our courier goes at midday. But also we do know that there is a little bit of a daily variation or a variation during the day of testosterone levels, not so critical in women actually as it is in men. So there's a bit more tolerance in the other in female blood testing, but do avoid applying testosterone that morning. We want to avoid any local contamination, and also making sure that the person who's doing your blood tests is avoiding any potential to contaminate the blood draw site. Sometimes we've had super high levels of testosterone, repeated them, and actually they've been perfectly normal. And the only conclusion we can draw there is that some contamination happened. So what can you expect when you start? Well, it should restore your blood testosterone levels over time back to the normal range for you, and that usually improves tiredness, brain fog, low sex drive, among other things. I mentioned side effects earlier. Usually there are none. Truly, people tolerate testosterone pretty well because it's given to replace the testosterone that you're otherwise lacking. So aside from this local hair growth area, it's unlikely to show any other issues, and particularly if we're monitoring the free androgen index. As this dose is so low, it doesn't usually increase your risk of developing facial hair. I know that's a concern. People think, oh my goodness, am I going to start developing a beard? Frankly, I had hair growing in the wrong places before I started testosterone. Unfortunately, it's a sign of the times. Hair grows in all the wrong places. but voice deepening or skin changes, it's unlikely to happen. A couple of women have mentioned where they've been prone to hormonal acne, that sometimes that flares up a little bit when they first start. I've only seen that once or twice, and it's settled very quickly after a week or so. The key message here is it's important to keep in touch with your healthcare provider and to have regular blood monitoring to reduce the risk of any side effects occurring, and also to keep close so that you can find the right combination of hormones for you. It is safe to take alongside your estrogen HRT. In fact, it's critical to have it with your estrogen HRT and vaginal estrogen. And at the moment, safety profile of testosterone, the evidence around that is that it's not associated with any adverse health risks and has been shown to be beneficial. I mentioned HSDD, or hypoactive sexual desire disorder, earlier. It is, of course, normal to go through phases of less interest in sex. There's much going on in everybody's lives. And it's important to understand whether that's the sort of waxing and waning of life and the challenges that happen in all relationships, or whether it's something more significant. So HSDD is identified if you have a total lack of interest lasting for more than 6 months that's having consequences on your relationship or self-esteem. So signs include no interest in any type of sexual activity. And I think that's important because it differentiates somewhat between relationship issues. If you're not having any sexual thoughts or fantasies, like that bit of your brain is completely switched off, you're not interested in initiating sex, whomever it might be with, you're not having any thoughts or fantasies, you're not getting any pleasure from it, and that includes masturbation, then HSDD is very likely. And there are some questions that are asked when we're considering a diagnosis of HSDD. So we can certainly help with testosterone replacement, but there may be some other things that need to be helped and supported as part of that. So you can see on the screen that there's a range of questions there, but we do need to rule out whether any particular medications you're taking. And interestingly, the SSRIs, so the serotonin reuptake inhibitors, such as citalopram and sertraline, can significantly reduce libido. So it's worth noting that we take a full drug history, of course, when we talk to our clients, but making sure that there are no obvious reasons why you might be feeling the way that you are. And it may be that you've been through some trauma that needs to also be dealt with. You may just be hugely stressed. Your partner may have some issues as well, which makes connecting in that way very tricky. So there's lots and lots of different reasons. And of course, we can explore those and do what we can to help. So I want to talk a little bit about the regulatory framework, because I think it's important to know the context in which we're prescribing testosterone. And I kind of touched on this. So there's no licensed testosterone product for women on the UK market. So what this means is that a product hasn't been registered and approved by the medicines regulator, the MHRA, for use in women. For this to happen, a pharmaceutical company has to go through trials, often lasting many years, and submit safety and efficacy data from those clinical trials. Performing clinical trials in healthy women is more challenging and difficult than in men because of the risk of pregnancy. So there are lots of rules around doing drug trials, as you can imagine. So it simply hasn't happened that an application has been made and been successful to date. Now, that doesn't mean that it won't happen in the future. And I would imagine, given the significant interest in this space, that I'm hoping that it's imminent. Now, it's not unusual for prescribers to prescribe medicines and for pharmacies to supply medicines that are not licensed or are being used off-label. So if they're not licensed, that means an application hasn't been made to license that product. So it just simply doesn't exist as a licensed product. Or it could be used off-label, which is that it is licensed for a particular condition, or a group of individuals, but it's not licensed for a particular indication. So an example might be that there's a product called acetazolamide, which is commonly available, has been for many, many years, and is the recommended treatment for prevention of altitude sickness. It is not licensed for that, but it's accepted that it's commonly prescribed for that condition. So the issue, I guess, for us with testosterone, if it is an issue, I'm not sure it is a big issue, but you need to know about it, is that all patients should be informed whenever a product is being used off-label or unlicensed. Now, testosterone that is used and prescribed as the male product is licensed as a male product in the UK, but is not licensed for women. And so therefore all the dose and safety and efficacy data, as well as the stability data, is all based on its use in a particular dose and not the dose for women. And then the product that we import from Australia has been licensed, has been tested for safety and efficacy in women, but not in this country. So that's why we prefer to prescribe the Australian product. So your GP, as I mentioned, may prescribe the male products. And the downside, I think, for that is that you've got to use much smaller quantities and it's difficult to measure and regulate a consistent dose. And if you're taking it from a sachet, which is often commonly used, the gel is exposed to the air. You have to kind of seal it. Actually, one of those little plastic peg things is quite helpful, but it can affect the stability if it's exposed to the air. We just don't know. But many private providers such as us will go for the cream imported from Australia. And the typical starting dose, as I mentioned, was 0.5 millilitres or 5 milligrams applied daily. And a tube will last about 3 months. So that's the kind of regulatory legal framework. The other thing to say is that because testosterone is an androgenic hormone and is potentially therefore a drug of abuse, because some people inject huge quantities of testosterone to improve their muscle mass. Testosterone is what we call a controlled drug, but it's actually at Schedule 4. It means that it doesn't have the same regulation associated with it as many controlled drugs, but it does mean that your prescription has to be filled within a month of it being written. So just a tip there, if you're hanging on to a prescription, it will expire after a month rather than the 6 months for normal prescriptions. So in summary, and we're coming to the end of this webinar, it's an important female hormone that declines as we go into perimenopause, and we're left with around less than 50% of the levels we had in our 20s. It's an important hormone that works in the brain for libido and sexual satisfaction, but it does also have many other functions, especially in cognitive function. We are replacing body identical hormone, and it's safe to use through the skin, applied as a cream or a gel. And we do use monitoring of blood levels to keep within the female therapeutic range, and this avoids side effects. There's no current licensed female testosterone product in the UK. However, there are a number of options that we can use and are regularly used and are indicated in the NICE guidelines. But it also includes an imported licensed product from Australia. And many women that we engage with describe testosterone as being the game changer in their HRT regime. So I'm now going to pause for questions. If you haven't posted a question, then now is the time to put that in. And see what I've got up on the post so far. So I've been asked, where can we find your other talks? Well, the good news is that because you've registered for this one, we will be sending you a summary of all the other talks and webinar links so that you can dial into those and listen. So do touch base with those recordings. And then somebody has mentioned that they were having problems with the audio. I'm really sorry about that. I hope everybody else has heard me okay. And a recording of the presentation will be sent to your emails. Brilliant. Somebody just thank you, Cleo. You just responded to my answer, which means that you can all hear me, which is always also a worry after such a 45 minutes of talking. I did have some questions sent to me pre the webinar, so I'm just going to make sure that I've covered those. The questions I was asked: does it need to be prescribed by GP or can it be done privately? Actually, a lot of testosterone prescribing does happen privately, and we're very happy to take on clients who are looked after by their GP for their estrogen and their progesterone, and top up with testosterone. But we do make sure we've got a full history so that we can optimize all of the hormones. How often do you need to have blood tests once you're taking it? I hope that's come through at baseline, at 3 months, and annually thereafter. This question says, anecdotally, I've heard of some women growing additional or thicker hair in the area where the gel is applied. How can this be avoided? I hope I've covered this, but essentially you can change the site, or you can do what I do, which is wax the site from time to time. For me, it's a small price to pay for the benefits. And the other point here was, I've also heard of women growing facial hair. Can this be avoided? Is it a sign of taking too much testosterone? I suppose potentially yes, if people are not being monitored appropriately. And certainly if someone felt that that was happening after initiating testosterone, then it might be a good idea to have a blood test sooner rather than later, just to make sure that we're keeping everybody in the therapeutic range. I've had someone ask, say, I live in Ireland, can I help? Certainly from a regulatory point of view, if you're in Northern Ireland, yes, not in Ireland, but I'm very happy to have a conversation. Why don't we touch base offline? And if I can help as part of the consultation and make a recommendation that you can take to your doctor, then that might be useful. That pretty much wraps up all the questions that I've got here. You've got my email address, I hope, or a way of connecting and contacting with us. We will be sending out the recording to this webinar, and you can always contact the clinic at any time to make an appointment, have a consultation, or have a conversation. Here's the list of the webinars that we had in place before, so we will send those recordings out. And you can directly book online. By magic, that QR code should take you to the website page. It's just been such an amazing experience to work with clients and to really be able to help them and see the difference that HRT can make to their lives. But I can only reflect on my own journey that I certainly wouldn't be able to do what I do at 59. You know, I feel like I'm being the most productive that I've ever been in my life. And certainly I know getting my hormone health right has been part of that. So that's it this evening. Thank you so much for attending. It's been an absolute pleasure. And do let us know what you think. And we will be communicating all of the recordings out to you in the next few days. Take care and thank you.